Hey clinicians, today I'm diving into the ins and outs of Medicare's incident to billing guidelines. Get ready to unlock some secrets that could significantly impact your practice's bottom line. So, what exactly is incident to billing? It's a Medicare guideline that allows certain services provided by non-physician practitioners, think nurse practitioners, NPs, or physician assistants, PAs, to be billed under a supervising physician's National Provider Identifier, or NPI, at 100% of the Medicare fee schedule. That's a big boost compared to the usual 85% rate for NPPs. Let's break down the key guidelines for incident to billing. First up, this applies to Medicare patients only. Don't assume commercial insurers will recognize it. Second, the physician must perform the initial visit, establish the care plan, and stay involved in the patient's treatment. Next, the service must be part of an ongoing treatment plan established by the physician. Another crucial point, direct supervision. The supervising physician needs to be physically present in the office suite and immediately available during the service, but doesn't need to be in the same room. Also, the NPP providing the service must be employed by or under contract with the supervising physician or the same group practice. The services have to be provided in a non-institutional setting, like a physician's office or clinic, not in a hospital or skilled nursing facility. If all these criteria are met, you can bill under the supervising physician's NPI at 100% of the Medicare physician fee schedule. The services must be medically necessary and within the scope of practice of the NPP, and proper documentation is key. Make sure to note the supervising physician's involvement and availability. If the patient presents with a new problem or a change in condition, the physician must see the patient before NPPs can resume providing incident to care. Common pitfalls: failing to meet direct supervision requirements, billing incident to for new patient visits or new conditions, providing services outside the office setting, and billing for non-Medicare patients under incident to rules. Now let's look at a clinical scenario. Imagine a 72-year-old Medicare patient with hypertension and diabetes visits a primary care clinic. First, the physician performs the initial evaluation, documents the patient's history, assesses the conditions, and creates a treatment plan. Lifestyle modifications, metformin for diabetes, and lisinopril for hypertension are prescribed. The patient is instructed to return in 4 weeks for a follow-up with the NP. 4 weeks later, the patient returns. The NP monitors blood pressure and blood sugar control, follows the treatment plan, reviews glucose logs and blood pressure readings, enforces dietary modifications, and adjusts medication as per the physician's original plan. The supervising physician is in the office suite, available if needed. This service is billed under the physician's NPI at 100% of the Medicare fee schedule. When would incident to not apply? If the patient reports new symptoms or if the supervising physician is not present, the service must be billed under the NP's NPI at 85%. Also, incident to billing is not allowed in a hospital or skilled nursing facility. And there you have it. Unlocking the secrets of incident to billing can optimize your practice's efficiency and revenue. Thanks for watching.